at the University of Nottingham. You're also the past editor of Gut, member of the board of the Rome Foundation, and author and co-author of around 388 scientific publications. So quite a heavyweight we have here with us tonight. His research interests include particularly pathophysiology of IBS, the role of infection, inflammation, diet, and alterations in the microbiome. The title for this evening, Professor Spiller, I'll leave that up to you. Thank you so much for joining us.
My pleasure. So let's just press the button. Let's see whether we can get it to. So hopefully you can see this. And we'll start at the beginning. Okay. So, well, good evening, ladies and gentlemen. It's a great pleasure to be asked to give this lecture. It's a topic that's interested me for many years, and I hope to share with you some of the research we've done in Nottingham. Now, we thought before we started the lecture, we would ask you 3 questions. So Valentina's going to show a poll, and we're going to get you to answer this now, please. And we will run the poll again at the end, and then we can decide whether we've learned anything. I hope so. Over to you, Valentina. So as you can see, there are 3 questions. I'm going to give you, okay. Very good. So that's good. Okay. So there's plenty to learn, and let's go on to the next slide. So here we go. These are my disclosures. And I'm going to start with a clinical case. So this is a lady that I've seen, a 35-year-old supermarket worker. She's got 12 years of chronic abdominal pain. Most days it's relieved by defecation. She has bloating and an erratic bowel habit. So she has both hard and soft stools. She's got no alarm symptoms, but she has been worse recently. And she's been to a primary care doctor, and he's done some tests, done a fecal calprotectin, which is normal, and a full blood count. And he's excluded celiac disease by getting a negative tissue transglutaminase test. You examine her, or I examined her, and she had a normal physical exam. And she's tried mebeverin, she thinks it has a little benefit. She's tried low-dose tricyclics, amitriptyline, but she made her sleepy. And she's tried linaclotide, which just gave her diarrhea. She thinks that bread makes things worse. And she's tried excluding lots of foods, including wheat and dairy, but she's confused because the effects don't seem to be consistent. So basically, she meets the criteria for IBS as shown in the Rome 4 manual. She's got recurrent abdominal pain. It's related to defecation. It's relieved by it. And she's got changes in stool frequency and form. So how common is it? And this is a map of the world showing the incidence of IBS, and you can see that it can be found in many countries. There's 2 maps here. This one is based on an internet survey, and this one is based on a household survey to ensure coverage of populations which don't have access to the internet. So you'll note that the incidence ranges from a low of around 1.5% to more than 5%. And you may say, that's rather low, isn't it? Because you may be used to the old criteria, which were Rome 3. And it's true. Rome 4, the incidence using Rome 4 is much less than Rome 3. And the reason is that Rome 4 requires pain, and people who don't have pain are now in the category of either functional constipation or functional diarrhea. And if you add that together, you can see it's still a very common condition. So back to our case, she's referred to a dietitian who documents an erratic eating pattern with a reduction in fruit, vegetables, dairy, and bread. So she's avoiding lots of foods. And she's not, this is not uncommon. Here's a survey from Ireland of 135 IBS patients and a group of healthy controls. And they were asked what foods did they avoid. And we've listed here the different foods. So the most obvious one is wheat. So nearly a third of IBS patients are avoiding wheat, compared with a much lower number of healthy volunteers. But there are also restrictions. IBS patients, about 20% of them avoid at least one vegetable, and some of them avoid all vegetables. And about 10% avoid at least one fruit, and likewise dairy products. So she's pretty typical of IBS. So what does the dietitian do? She gives her a strict low FODMAP diet for 4 weeks. So we need to explain what a FODMAP is. So it's a fermentable, it's an acronym. So it's fermentable oligo, di, monosaccharide, and polyhydric alcohol. And I've just illustrated with the pictures the sort of foods that have these things in it. So the oligosaccharides are the fructans, the galacto and the fructo oligosaccharides. And these are found, fructans in bread and onions, the galacto oligosaccharides in beans and fruit. And then, of course, there's lactose, which if you have lactase insufficiency, this will act as a FODMAP. And then there are the monosaccharides like fructose and xylose, which aren't particularly well absorbed and found in lots of fruit. And then there are the polyhydric alcohols. These are the lovely sweet things that make plums and other soft stoned fruit taste so delicious, but they are a FODMAP. So the meal-induced, the mechanisms underlying the FODMAP-induced symptoms, I'm going to illustrate here. So there are immediate effects which occur within a few hours, and these are driven by osmotic properties. So the monomers, that's fructose, mannitol, sorbitol, and lactose, these are small molecules. They have an effect in the small bowel, which is very permeable, and they drag water into the small bowel, which is increased. This has the effect of accelerating movement through the bowel, and it distends the bowel as well by a factor of 10 to 15%. And then there are intermediate effects which occur 4 to 12 hours later. These are based on the entry into the colon where fermentation occurs. And these are the medium chain and the FOS and the GOS and the macropolymers, all of which are not absorbed and so enter the colon. And there they are fermented. They produce gas. They distend the colon. They also are metabolized to short-chain fatty acids, and the pH falls, and there's a generation of lactic acid, which might be important in symptoms. And the transverse colon is the one which accommodates most of the increase in volume. And don't forget, there are also delayed effects, which might take days or weeks. And this is based on the changes in the microbiota. Many FODMAPs are also prebiotics, and there's a change in metabolites with this change in microbiota. So the effects of FODMAPs are not all bad. Now, here is a picture worth 1,000 words. And this shows the small bowel response to fructose and fructans. And these images are from a single individual, 75 minutes after they've taken 500 mils containing either glucose or fructose or a combination of the two or fructans, all in the same dose. Now this, for those who aren't used to it, this is the gallbladder, this is the stomach, this is the small bowel. And you can see in this individual at 75 minutes, half of the 500 ml test meal is gone. So there's only 250 mils left in the stomach, and the rest has virtually disappeared because glucose is very well absorbed. By contrast, after the fructose, although the stomach has emptied to the same degree, there's a large amount of water in the small bowel, probably more than the 250 that has emptied, maybe up to 400. And this is because fructose is not well absorbed. Now, when you combine the two, you get slower gastric emptying because it's now hypertonic, but the material that does enter the small bowel, the glucose and the fructose together, that is very rapidly absorbed because glucose facilitates fructose absorption. And then finally, we give the fructans, and they are low osmolality. They empty from the stomach quickly, but they don't produce much change in small bowel water, which you'll see in a minute. Now, the fructans have their effect in the colon, where gas is increased. And this is just an illustration of this. So this is an individual at baseline. You're looking sideways at the ascending colon. This is the liver. And then at 75 minutes, a little bit of gas. And at 255 minutes, it's entirely filled with gas, although in this healthy volunteer, it caused no symptoms at all. So this now becomes the key question. Do IBS patients respond differently to FODMAPs than healthy volunteers? And this is published in Gastroenterology in 2017. We took 29 IBS and 29 healthy volunteers, and we showed that small bowel water does increase with fructose, as we found before. So I'm showing you now the patient data, and the fructose produces a rise and then a fall. Glucose produces no change, it's very well absorbed, and the inulin didn't produce any change either. I'm not showing you the healthy volunteers, but they were the same. And now we look at the colonic volume, and you can see that while glucose produces no change in colonic volume, the inulin, the one that's not absorbed in the small bowel, enters the colon and produces a rise of over 150 mils in the colon. And then we looked at gas, and that shows a similar pattern. So the green, the inulin, is producing the biggest increase in gas, much smaller increase with fructose, and very little increase at all with glucose. Now, what about symptoms? And here we did a symptom score. We asked the patients to measure gas, bloating, and abdominal discomfort. And if you plot the maximum rise in the symptom score against the maximum rise in colonic gas, there's a reasonable correlation here with inulin. So inulin increases colonic gas, and as it does that, it generates more symptoms. When we look at the fructose study, the main effect, it didn't have much effect in the colon, but it did have a big effect in the small bowel, and that's where the strongest relationship is. But the surprise to us was there was no difference in intestinal volumes between the healthy controls or the symptomatic or the asymptomatic IBS. And our conclusion was from this study that, that essentially the physiology is the same, but the difference is that the patients are responding to it because they're hypersensitive. So they feel the same stimulus and get pain when normal people do not. So what about our clinical case? How did she get on? Well, she found the diet difficult and expensive to follow. She complained about that, but she did comply with the diet, and she responded well. She got much less bloating, she got fewer loose stools, and she was less flatulent. It's worth noting that while she's restricting her diet and avoiding things, her calorie intake actually fell, and that might not have been a bad thing because she was a bit overweight. So just to now consider how common this condition is. So she's one of the things she excluded was wheat. How common is wheat intolerance? Well, in a big survey of over 3,000 Australians, they found that 12.9% had IBS, and this is using the Rome 3 criteria. I mentioned this has a higher level than Rome 4. So 12.9% had IBS, and 14.9% had wheat intolerance. And when we looked at the overlap here, you can see that 35% of the IBS patients had wheat intolerance. And when we look at the link there, so you were 3.6 times more likely to have IBS if you were wheat sensitive, and 1.5 more likely to have functional dyspepsia. So they are linked. And I want to persuade you that wheat intolerance is most likely due to the fructan content and not gluten, because many people who are excluding wheat think they're sensitive to gluten, and they're probably not. So the basis of that argument is as follows. First of all, wheat is the largest source of fructan in the Western diet. So 2 to 4 grams of fructan in wheat, and this is data from the United Kingdom, and this is from the United States. And then the next bit of the evidence is this trial reported from Australia in Gastroenterology. So these are IBS patients who thought, they reported that they were gluten intolerant. So they were on a low gluten diet. They excluded everybody who had really got celiac disease. So these were IBS patients. And they did a 2-week run-in diet of a low FODMAP diet, and then a placebo-controlled trial of either high gluten, low gluten, or a control. The control was whey protein. And what they found was that the 2-week diet, the low FODMAP diet, led to an improvement in most of them. They had quite a big improvement in symptoms. But when they went on to the gluten challenge, they couldn't distinguish placebo from high gluten. And interestingly, the ones who were receiving this challenge got worse over the week. So the authors described what they called a nocebo effect. That is, that if patients are given a food they think they're intolerant of, they will get worse symptoms. And that's important to recognize. Okay, so what about the overall effectiveness of the low FODMAP diet? Now here I've drawn on this meta-analysis and review, which summarizes a substantial number of studies. It's worth noting that the endpoint of these studies varied. It was either the IBS severity using the IBS symptom severity scale or pain intensity. And in order to enable them to compare studies which had different endpoints, what they're reporting here is the standardized mean difference. So this means that you can compare studies with slightly different endpoints. The green is the median, and you can see that the majority of them favor the low FODMAP diet. The error bars are quite wide, but when you add them all together, it's pretty convincing that there is a benefit. So I think we're pretty well agreed that that's the case. But now I want to ask a different and possibly more important question, and that is the effect of a low FODMAP diet on the severity score, is it clinically significant? And here we're showing the studies which used this widely used symptom severity scale. And here are the absolute values, and you can see that there's a median reduction of 45. It's clearly significant, but I want to emphasize to you that this is not a panacea. This is actually quite a small effect. It does work, but don't expect miracles. There are lots of other causes of symptoms in IBS, and the diet won't necessarily fix them all. Now, I'm going to spend a short while describing one study because I think it's rather good, and you get more detail than a meta-analysis. So this is one of the best studies, I think. It's a large study, 104 patients. It used a factorial design. So they had a sham diet and a low FODMAP diet, and they had either a probiotic or a placebo. And both diets were described as altering carbohydrate intake and included an equal number of exclusions. The authors went to a big effort to make sure that the sham diet and the low FODMAP diet appeared similar. People couldn't really distinguish which was which. The probiotic was a multi-species probiotic. It's a yogurt starter type probiotic. And the logic of that was the low FODMAP diet restricts some bacteria. The idea was maybe you could replace them and get a beneficial effect. Now, the details of the diet are shown here. I won't go through it all, but I just want to make a couple of points. They were matched for energy, and the energy intake, actually, when you go on a diet like this, you do reduce your intake because you're cutting out quite a lot of things. They were matched for protein and fat, and the differences are in the FODMAPs. Now, a low FODMAP diet is not a no FODMAP diet. They reduce the FODMAPs about 50%, but you're still taking quite a few. The big reduction is in the fructans. That's largely by excluding wheat. in lactose by excluding dairy products and using substitutes, and fructose by, again, excluding things with high fructose. And what were the results? So this is the IBS symptom severity score, and this is the total score, and these are the components of the total score which you add up to get the result. And I guess the important message is to look at the p-value. There were significant reductions in all of them, apart from the pain severity. And the overall change with the low FODMAP was a fall of over 100, which is quite a big fall. That's quite a big fall. But notice the sham diet also produced quite a big fall as well. So people do respond to a placebo. They do respond to the attention they get from a dietitian. Now, using a more conventional measure, which is, did you get adequate relief from your IBS? There were differences. The low FODMAP diet, nearly 2/3, the sham diet about 1/3, so a not quite significant difference, but a substantial difference. And per protocol, because some of the people didn't stick to what they were supposed to do, a slightly cleaner result with a significant difference there. So back to our case, she now went into the reintroduction phase. So this is really important. After 6 weeks on a strict low FODMAP diet, you start reintroducing the FODMAPs with sequential 2-day challenges. So with this lady, the first thing she did was to try bread to confirm whether or not bread caused symptoms. And she quickly worked out that bread, onions, and green apples were the key things that she was eating that gave her an adverse reaction. And if she avoided those, she could get away with most other fruits and vegetables without a problem. So she could get back to a much more normal diet. And after 6 months, she's doing quite well and not too restricted socially. So what about the evidence on long-term prognosis? Because this is really important. It is a long-term treatment. And there are not many studies, actually. But this is a study from India, 101 patients, a good-sized study. They were randomized to either the low FODMAP diet or the traditional dietary advice, which is, avoiding fizzy foods, eating regularly, avoiding too much caffeine and alcohol, and various traditional advice. So they got 4 weeks of the low FODMAP diet, and then they had a phase of re-challenge, as I've described, over a period of 16 weeks, and they were evaluated as shown here at baseline at week 4 and at week 16. And you can see that the overall symptom severity score fell. So this is moderately severe, and it fell to remission, basically, on the low FODMAP diet at 4 weeks. And during the introduction, there was only a small rise. The traditional diet also showed a fall, but not as much, and this continued at 16 weeks. So it's nice to think about responder rates. So if you call a responder somebody who has a fall of more than 50 points, which is what is conventional, then you can say that 2/3 of the low FODMAP diets versus 40% of the traditional, so a delta of 22%, quite significant. And at 16 weeks, you've still got a similar size difference. So the effect does seem to hold up. What about the details of the reintroduction? So here's the effect on stool. So on the low FODMAP diet, they had a fall in stool frequency. Actually, I think that's consistency. I think it's the Bristol Stool Scale. I'm sorry, the mistake misleading you there. This is the number of stools per day. So there's a reduction on the low FODMAP diet and a smaller reduction on the traditional diet. Compliance is important. Can people stick to these diets? Well, they got 93% managed to stick to the diet at 4 weeks, much fewer at 16 weeks. And the same is true of the traditional diet. Compliance is not as good over a prolonged period. However, on the more positive note, 1/3 of the people taking the low FODMAP diet were able to reduce their drug intake for IBS significantly below. They've taken less than half what they started off taking, and a smaller number on the traditional diet. So this was certainly a measure of effectiveness if people don't have to take medication. Now, our theme tonight is focused on the gut microbiome because, of course, the low FODMAP diet alters the gut microbiota. The FODMAPs are what the gut microbiota feed on. So this is one of the earlier studies, 2012. The intervention was a low FODMAP diet versus a habitual diet. It was a 4-week intervention, and they looked at the stool for metabolites and for the microbiota. And I'm just going to show you this slide showing the effect on bifidobacteria. So there's a change. Remember, this is a log scale. There's a change from 7.4, from 8.2 on controls. It fell nearly a log unit. So that's nearly a 10-fold fall in bifidobacteria. Otherwise, there were no other significant changes in bacterial numbers, and there was no change in the short-chain fatty acids. This shows the microbiota data. So the bifidobacteria fell on the low FODMAP diet. The probiotic, which contained bifidobacteria, seemed to reduce that fall there. The probiotic increased the streptococcus, not a surprise because it contained streptococcus, but there was no effect on the lactobacilli. Now, we've got a pretty strong idea that the FODMAPs work through metabolism by the bacteria, which produce volatile organic compounds, and they're very complex. This is a principal components analysis of the fecal volatile organic compounds, the VOCs, of which there are about 30, and you can see that they were able to separate out responders, shown in brown here, round circles, as against the non-responders. So they do seem to be different. Exactly what this means is not clear, because the volatile compounds, of course, they're numerous and we don't know what they all do, but there does seem to be a difference in the metabolism of the fecal microbiota. Well, that's not much use to us really in the clinic. So what can we use to predict who's going to do well with the diet? Well, happily, at least one patient symptom is useful, that is chronic diarrhea. So if people have got chronic diarrhea, they're 3 times more likely to respond. This study showed that patients with greater dysbiosis, this was measured by a DNA test on the stool, which is not widely available, but it's supposed to measure a change of the normal microbiota compared with controls. And so people who appeared to be more different from controls didn't do so well. But I'm not sure how to interpret that, but I'm going to dwell on this study, which does make a bit more sense. And they found that patients with abundant saccharolytic microbiota, i.e. the ones that could use the FODMAPs, were more likely to respond. So let's just look at that in a bit more detail. This is done in children. It's a double-blind crossover trial in children with Rome 3 IBS. They had a 1-week baseline, and then they were randomized to just 48 hours of diet. So remember, these are children. 48 hours is a long time in the life of a child. So that's all they did. And they gave them one diet and then they switched them over to the other. Okay. Now, these diets were extremely different. So the low FODMAP diet was less than 9 grams a day, and the traditional American childhood diet was about 50. So this is driven by consumption of these high fructose soft drinks that Americans seem to love. They defined a responder as a more than 50% reduction in the number of abdominal pain episodes, which seems fair. And they used this complex bioinformatics to generate some predictions. From this program, you can use the 16S RNA gene sequences, which are linked to the Kyoto Encyclopedia of Genes, and try and predict what functions you'll have. So what do they find? Well, they got fewer abdominal pain episodes on the low FODMAP diet. So on the low FODMAP diet, they got 1, and it was that was nearly half what they had on the typical American diet. So 8 of them met the responder criteria. And when we looked at the breath hydrogen, which is a measure of fermentation in the colon, you can see the low FODMAP diet, as others have reported, produces a big drop compared with this diet, which has got a lot of fructans in it. And when they looked at the microbiota, the responders were enriched with groups of organisms that had greater saccharolytic metabolic capability. And these were Bacteroides, Ruminococci, and Faecalibacterium. And when they looked at the Kyoto Encyclopedia, they found 3 sets of genes, of which 2 related to carbohydrate metabolism. So this certainly seems to make sense to me. Now, in the last few minutes, I'm going to share with you some study we've only just published. It was published a month or 2 ago in Gut. And we were exploring there the use of psyllium to modify the response to FODMAPs. Now, we know that psyllium, when combined with water, produces a high viscosity fluid, and it also gels. We know that it benefits IBS. We've had some early clinical trials suggested benefit. And we know that FODMAPs, when they're fermented, produce gas, which distends the colon and stimulates the colon motility, and we think this drives IBS symptoms. So the low FODMAPs diets improve symptoms, but they may have negative effects because the microbiota, as we've seen, you get less bifidobacteria, for example, which most people think are probably a good thing rather than a bad thing. So our question was, if we combine psyllium with FODMAPs, could we improve tolerance and thereby avoid restriction with its possible negative effects? And this is the EFIGI study, the effects of fiber on intestinal volume and gas in irritable bowel syndrome. We had 19 IBS patients divided between constipated and diarrhea. And they went on a low FODMAP diet before the study. And then they were given a test drink containing either inulin or psyllium or the combination or dextrose, which is our control. And the breath hydrogen result is shown here. And you can see that when you take inulin, after a while the material moves down the small bowel and enters the colon, you get a rise in the inulin with a little kick up after the meal when the terminal ileum empties its contents into the colon. When you combine it with psyllium, this line is very much reduced. And when you give dextrose, you get no response, and give psyllium alone, which is not fermented, you get no response. So we certainly seem to have been able to achieve what we wanted. And then when we looked with our MRI, we were able to show that this is colonic volume now in mils over time, and you can see that the inulin produces a 30 to 40 mil increase. Remember, looking at the ascending colon here, it's only 200 mils, so 30 mils is quite a big proportion, and this generates symptoms. Whereas with the when you add the psyllium, you get a much smaller response. So time is up. I would advise you that if patients say they're intolerant to food, you should take that seriously, and they may well be right. FODMAPs can cause pain by a number of mechanisms. They can have osmotic effects in the small bowel. They can produce fermentation products in the colon and gas. I would suggest to you that there's good evidence that low FODMAP diets can produce modest improvements in symptoms. Don't expect miracles. It does work. It's better than placebo, but the effect is not huge. If you want to get the best results, choose non-constipated IBS patients. And I've shown you just a bit of our own special interest that psyllium can reduce gas production. And I'm thinking this is something well worth trying in the future. So I'm going to wrap up by just thanking all the people in my team who work with me and have done so over many years. I particularly mention Penny Gowland, who's, I would say, the brains behind it, and David Gunn, who did the studies that I showed you just recently on psyllium. So thanks very much for listening. And I think I'm going to ask Valentina now to show the poll again. So please answer this now, and we'll take it from there. Right. Excellent. So, well, I regret to tell you that fructans don't have an effect in the small bowel. These are the, maybe I didn't make that clear, these are the long polymers, the macropolymers. They don't have osmotic effects. It's the small ones, the fructose and the xyloses. So the 50 grams of fructose is usually beyond what most people can absorb. And adding glucose to fructose does indeed include its absorption. So that's, some of you got that right. Okay, second question. Yes, you've definitely got the message there. It's really all about sensitivity. Healthy volunteers also get large gas volumes, but they don't get any symptoms. And good, I'm pleased to see that you have got the message that if you want the best results, then non-constipated IBS are going to do well. The probiotic actually didn't show much benefit. It was pretty marginal. And most of you are right in not choosing that because the low FODMAP diet reduces bifidobacteria. Okay, so we'll close the poll, and I'm happy to answer any questions.
Professor Spiller, thank you so much. Are you there? Yes, both of you. Can you see me? Can you hear me?
Yep.
Good. So good to have you. Thank you so much for this wonderful talk. Very clear. At least I learned something tonight. And as we could see, at least on some of the questions, we also got a significant improvement. So let's now take some of the questions that we have here. Let's start with some of the questions that do refer to the FODMAPs, and let's start with a simple one maybe, which is actually quite complex. What do you recommend as a simple way to bring across the concept of FODMAP to patients in your day-to-day habits, in the day-to-day practice, because most people will find it difficult and difficult to adhere also to the instructions. So what do you recommend on a practical level?
Yes, you're right. Diet is very complicated. And in truth, most people who use the low FODMAP diet will use a dietitian. And the dietitian will typically spend an hour explaining to the patients. So it's not an easy thing to do in a brief consultation. And obviously, it's the best thing to do is to say, look, I think it may be something in your diet that's causing your symptoms, and I want you to go to see a dietitian. The dietitian will spend a lot of time. They will take a dietary history. They will evaluate what the FODMAP intake is. They'll identify the key things, and they will explain the ideas of the FODMAPs. Now, obviously, explanations have to be tailored to the patient's level. So someone who's highly educated and understands the physiology, you might want to tell them about the effects and how they distend the bowel and how they get fermented. Somebody with lesser understanding, you might want to keep it really simple and just say, you've got to avoid the simple things. In Australia, for example, the low FODMAP diet is widely used, and people have an app on the mobile phone. They can go to a supermarket, they can point their phone at the food product, and it'll tell them what the FODMAP content is, which is amazing. That's probably too obsessional, I'd say. For many people, it will be quite simple. It will be mainly wheat, dairy products, and various fruits that are causing the problem. But I think the safest way of achieving the low FODMAP diet is for them to have the strict 4-week trial period guided by the dietitian, who typically will give them advice, give them a menu, say, this is what I suggest, and the patient says, well, I don't like that, so then they substitute something, so that they can construct a low FODMAP menu for individuals. Then if they don't improve, that's definitely excluded that as a possibility. And in truth, about 2/3 do respond. Some of them are doing it because of a placebo response, but quite a good proportion are doing it because it really is what's driving the symptoms.
Some people argue that the FODMAP diet is rather expensive. Do you agree with that statement?
Yes, I think that's correct, because the staples in life, the wheat and the things that people typically eat are relatively cheap. And if you try excluding wheat, and start buying gluten-free products, for example, they're pretty expensive. Yes, so I would agree with that. But having said that, it's a lifelong condition, and a 4-week period in which you can establish clearly what's driving your symptoms, that's quite an attractive option. And in terms of cost effectiveness, spending a little bit of money on that period is well worth it. And you have to remember that these patients are often taking quite expensive products which don't necessarily work. So yeah, I think it is expensive. You have to explain to them that it's worth doing.
Fair enough. Here we have a question asking whether there are side effects of FODMAP with diabetic patients in particular.
Yes. Well, as I said, if you take a lot of FODMAPs, you can, in animals, you can demonstrate injurious effects because the colon becomes acidic. There can be changes in the barrier function. So these are theoretically noxious effects. However, as a caveat there, because in animal studies, they're often given very extreme diets, which human beings wouldn't take. So it's still an open question whether FODMAPs actually cause any harm. They cause gas and they make the patients distended, but whether they do more than that is not clear. No.
Okay. You mentioned the 4-week period and saying, it's worthwhile also trying for 4 weeks what foods are good for you and which ones are not. Here we have a question whether you can give a typical follow-up, to your 4-week low FODMAP diet.
Yes. So again, it's better if the follow-up is done with a dietitian. And typically with our dietitians, for example, they not only offer the follow-up, but they also offer consultation ad hoc. So if a patient runs into a problem, they can ring them up and say, I'm getting these symptoms. What do you think I should do? Because the reintroduction isn't entirely clear. The patients may not have realistic expectations, and the dietitian may be able to help them as to what to expect. It's very important when they reintroduce food that they do it consistently. They need to give it a try because we all know that symptoms fluctuate, and one day might not be representative. So typically people give up rather quickly as soon as they get these symptoms. They stop taking it. It may not be the food. So they have to be quite controlled about it and give themselves a 2-day challenge and then decide. And then the dietitian can say, well, you're responding to this food, so this is probably what you should avoid. And they'll know, obviously, what other foods have got similar content of FODMAPs in them, and to know to avoid them as well. So
it's really taking it one by one, taking out restrictions, taking on restrictions on some foods, introducing them again, seeing what works.
Yes, and my advice is always to use the food that you most want to eat. So because many times people have got it wrong. They think that apples cause symptoms, but actually when they're challenged, they don't. So the point is that you choose the foods that are the most inconvenient and the most socially limiting, which usually is bread, actually. And I would definitely say that would be the first one to test, because after all, if you establish they are intolerant of bread, well, that immediately is going to have a big effect on the diet. Or on the converse, if you find actually they don't respond to bread, that's a big liberation. That means they can eat out more and they can go and see their friends. And so that's a good sort of principle, to use the things that are going to make the biggest difference if they are allowed to eat them and not exclude them.
We have a lot of questions here about probiotics. There's always those questions, do they work in IBS? You seem to have been rather critical. Can you maybe elaborate a little bit on your position on probiotics in IBS and maybe also in combination with the low FODMAP diet?
Yes. I think probiotics do work in some people, yeah. And certainly some patients think they have a great effect. The trials that have been done supporting them are of variable quality, and the meta-analyses are a bit uncomfortable, because typically a meta-analysis should be analyzing trials done with the same agent, and they're not. Most of the probiotics have got 1 or 2 trials, and so it's difficult really to compare them all. As I say, I think it's likely that they do have beneficial effects in a small proportion of patients, but I don't think they're very powerful agents, no. Some of them have effects, mild laxative effects, and they certainly help people with constipation, for example. But I'm not so convinced, and not, I can't put my hand on my heart and say this will definitely produce a good result for you. I feel more convinced. I think the evidence for the low FODMAP is stronger. Yeah.
Okay. There's always this question about mineral deficiencies and the like, and minerals, vitamins. When you
the low FODMAP diet, a lot of low FODMAP diets involve reducing intake of dairy products, which for many people is an important source of vitamin D and calcium. And so there certainly has been some concerns. But actually, if you do a diet with a dietitian, they will make sure that you have adequate calcium supplementation, and they specifically are very careful to choose the diet so that that does not occur. So I think you could be reassured, if it's under the supervision of a dietitian, they will have adequate calcium and vitamin D intake.
Okay. Do you see any differences between people already being vegetarians, vegans, or having any other keto diets were also mentioned in the questions? How do you see that in relation to FODMAP?
I think this is a very important point, and one of the problems with the trials, because you wouldn't have missed your notice that the confidence intervals for those trials is quite large. And one of the problems is that none of these trials have taken into account the existing diet. So quite a lot of patients have already reduced their FODMAP intake. And for them, of course, you couldn't expect the diet to have a big effect. So I think future trials should control for this. And I think it's an absolutely valid question. Will a vegetarian respond differently? Their microbiota is likely to be very different. Their colonic physiology is different. So I don't think I can answer the question, and I think it's a very valid one. I think people who are vegetarians would like to know whether FODMAPs are causing their problem or not. And I think there isn't the evidence. It's a very important variable.
Okay. So maybe starting, finishing, what is the biggest difficulty then in your experience that people face with a FODMAP diet?
I think it's comprehension, and I think that a well-educated patient will not find it difficult. The concepts are pretty clear. I think if you're not that well educated, you don't understand food chemistry, it's going to be really difficult. And that's where that's the skill of the dietitian, to adapt their explanation to what the patient can understand and to try and bring it home to them. So I think I don't think in a short consultation that a doctor can do the job. I do think you need a dietitian.
Super. Professor Spiller, thank you so much for your